All right, so we'll finish up chapter 32 here. As I was saying, some of that seafood, particularly the older, larger fish that have been in the ocean for some time, may develop ciguatera or ciguatoxin, which luckily is seldom fatal, but causes basically flu-like symptoms or symptoms of many food poisonings, so abdominal pains, nausea, vomitings, diarrhea, and whatnot. It's because it ingests something called dinoflagellates, which are very small organisms. They're kind of like a plankton, basically. It doesn't affect the way that the fish looks or smells or tastes or anything like that. So it makes it a little more difficult to detect. Now it is possible that it can have some additional effects, such as some paresthesias and some itching, muscle pain, tooth pain. But for the most part, it's not fatal. So for the most part, pretty safe. It just makes things miserable for a while. Occasionally, it will cause a respiratory arrest and coma, or bradycardia or hypotension. We also have histamine fish poisoning, or scombroid. 37% of the seafood-related foodborne illnesses are histamine release, and it mimics an allergic reaction where it causes some flushing of the skin, throbbing headaches, nausea, vomiting, diarrhea, abdominal cramping, palpitations, itching, hives, dizziness, and dry mouth. May occasionally also cause hypotension, bronchospasm, and angioedema, which basically will give the appearance of an anaphylactoid reaction. But in most cases, people, when they taste the fish, claim of it not tasting right. Something is off. The flavor is off. So people who have had these fishes before often will be able to, within a bite or two, say, "Ooh, I don't know that this fish is any good." The sad thing is, when some people have never had it, they likely wouldn't necessarily know that. So basically, we're going to treat it similarly to that of an anaphylaxis, if not almost identically. The things that we see, that flushing of the skin, the respiratory distress, itching and hives, it basically drives us to believe that it is an anaphylactoid reaction, and it very well possibly could be. But so treatment's going to be the same: oxygenation, supporting the airway, beta-2 agonists for bronchodilation as necessary. If we carry and can safely administer some oral Benadryl, that would probably be a good idea. And then treating for anaphylaxis, if absolutely necessary, of course, then breaking out some epinephrine to assist with some of the respiratory complaints. Remember, epinephrine comes into play when the patient is developing signs of shock and or respiratory distress. We also have lots of plant toxins. Many of the things that we have around the house actually do contain various toxins, whether they're in our homes or gardens, out in the field, out in the wild. We have an example on these next couple of slides here. I mentioned earlier that cyanide is found in most of the pits and seeds of the fruits that we commonly eat. In most cases, we are not going to have consume enough of them that it's going to have a severe or a fatal incident. However, it can cause some weakness, nausea and vomiting, occasionally some seizures or comas. Colchicine, which we find in a few of the common ornamental flowers that you may have around or at least see out in the wild, can cause things such as cramps, nausea, hematuria, shock, coma. Calcium oxalate or oxalic acid, the Dieffenbachia, the philodendron and rhubarb leaves is where you find these items. Causes the severe gastroenteritis, some burning and swelling of the oral mucosa, and can cause anuria, or inability to urinate or create urine. Amygdalin is parts of the wild and cultivated cherry trees, including the seeds, and it can cause some stupor, some vocal cord paralysis, seizures, and coma. The belladonna alkaloid, which we see in the Jimson weed, we've already talked about that when we talked about some substance abuse items of people with anticholinergic poisonings, which is commonly seen also in the nightshade. We see anticholinergic effects, so we have fever, tachycardia, dilated pupils, red hot skin, alteration in mental status. So remember that whole blind as a bat, mad as a hatter, hot as hell, red as a beet. So now the other thing about this is the drug atropine comes from the belladonna alkaloids as well. We use atropine as an anticholinergic. So remember, when we had a cholinergic poisoning, we're giving them 2-PAM and atropine because of the effects. So an atropine overdose would look like this as well. Glycosides, so the purple foxglove, it's a very pretty flower, but this is actually where we get the drug digitalis from, or digoxin. So lily of the valley also has glycosides in it. It's naturally been refined for us to use as a medication, but it can cause cardiac dysrhythmia in too high of a dose as opposed to treating it like it's supposed to. Nausea, shock, gastroenteritis. Solanine comes from the potato plant leaves or the green parts of the potato or the horse nettle. So if you have green spots actually in your potato, that's a part to definitely not eat. You don't eat the sprouts from the eyes. There's a high amount of solanine in those, and it's going to cause you to have some gastroenteritis, headache, potentially apnea, and shock. All from a potato, huh? So there's so many other poisonous plants. They just have a few listed: hyacinth, narcissus, daffodils, mistletoe, oleander, poinsettias, the iris, azaleas, rhododendrons, wisteria, castor bean. The castor bean actually is the source of ricin, which we know that ricin is a fairly ridiculous toxin. It can be used as a weapon of mass destruction. Buttercups, hemlock, and we can just continue to go on and on and on. So reminds us here that Jimson weed, sometimes it gets used as a drunk, an intoxicant. So it can be smoked, be drunk as a tea, and it is that potent anticholinergic effect. So we mentioned that up in the preceding slides, and it causes the altered mental state, flushed, dry skin, dilated pupils, hyperventilation. It goes back with our little saying, mad as a hatter, dry as a bone, red as a beet, blind as a bat, hot as hell. And there that is. So it's the anticholinergic toxidrome again. There's the amanita and the galerina mushrooms. So we have some magic mushrooms. Some of them are deadly magic mushrooms. So the amanita is the most common one that will actually cause death, causes liver failure. It can be a long-term, long, ugly death. The galerina is also quite toxic. And then we have some of the other plants that might give us some issues when we talk things like, we talked about those already. Talk about things such as poison ivy. Poison ivy can give you, or any of the poisons, poison ivy, poison sumac, poison oak, can give you basically a generally delayed hypersensitivity reaction. While they're not quote unquote toxic to us, they tend to be a huge irritant towards us. So they're very irritating cutaneously. So on the skin, causes a lot of itching and burning, welts. If you happen to inhale the smoke of some burning poison sumac, oak, ivy, what have you, you'll do the same sort of thing to the inside. So you will get the itching, painful, swelling of your respiratory tract, because the oils are released into the air, and the oils are the ones that are actually causing this reaction. Most people don't. Most people, it's an annoyance more than anything. Occasionally there are some people, though, that have some pretty severe allergic reactions to those. Let's see. So with plant toxins, again, very, very supportive care. ABCs, Ds, check glucose, establish an IV, oxygenation, ventilation. If we have an idea of what's actually causing it, if we can either take some with us, if it's safe to do so, maybe we can put it in a plastic bag, or get a couple of good pictures of the plant to help identify it. We can get those transmitted to either poison control or medical direction. ALS intercept is a possibility. Some of these things, again, we will have something we can do about. Many of them we won't. Sometimes we also have to consider what part of the plant was ingested, because we know that some plants actually, parts of them, like the potato, for example, are very edible and very non-toxic. You get the wrong potato that's gone green, or has you start to eat some of the potato roots, or something like the rhubarb plant. As long as you eat the red stuff, you're in good shape. It's actually pretty good stuff, whereas you start to eat the leaves and you're going to start to get sick. Now, honestly, eating a little bit of a green leaf of rhubarb is not going to affect most people. For most people, it's going to be, you're going to have to eat several leaves in order to start to have some sort of a reaction to it. So it's not nearly, I think most people were led to believe that you ate a little bit of green leaf off of it and you were going to die immediately. So that's not the case. Venom, probably my favorite part of this chapter. Many venomous insects and animals can cause a lot of local discomfort and swelling without producing a systemic effect. This part of the chapter may make a few people a little uncomfortable, because the creatures that we talk about here, at least two classes of creatures here, tend to give people the heebie-jeebies, the spiders and the snakes. So we also have the other classes of animals, whether we're talking about the flying stinging insects, which fall into the family Hymenoptera. So that's the bees and the wasps. We might be talking about the marine animals, such as things like sea cucumbers, corals, different types of anemones, jellyfish, and then of course our snakes and spiders. So in most cases, the patient will be able to relate a clear history of a bite, or will have the identified localized effects. So in many cases, people know when they were exposed. Now, occasionally, it's kind of a something that takes a little bit of thinking back, simply for the fact things like the brown recluse spider, they hide and they usually have a painless bite. So that painless bite might turn into a little bit of a sore, and not too long after the bite, then they start to develop their signs and symptoms. But initially, a lot of times it goes unnoticed. We also have infection risk with different bites and stings because they're out in nature. They don't use Purell hand sanitizer before they do their things. They don't brush their teeth. So we have an increased risk of infection. Take example, our spiders. We have two major families of venomous spiders. We have the recluse class of spiders, which is typically the brown recluse. They're actually called the Loxolese family. And then the Loxolese family is the brown recluse. There's a few sub-variations of brown recluse, although they all typically have a very similar look to them. and there's also the desert loxolese, which is very uncommonly seen in the United States, but is around, that may cause an envenomation. Now, the brown recluse spider, or the loxolese spiders, will often give you just a very small little bite like that, that 4 days later turns into something like that, and about 8, 9, 10 days after the bite turns into a big black, much larger than what we're seeing here, festering wound. The brown recluse was typically seen in the Midwest and the South. Yes, we do have them around here. They like seclusion, hence the name recluse. So they'll often go and find places to hide where they're not going to be disturbed. They have a very small, violin-shaped band on their back. That's evidenced in the book. And the bite is often painless, but it causes massive tissue destruction. So it is a cytotoxic venom that goes in there and starts to really dissolve the skin. So within about 8 hours of the bite, they're having pain now, swelling, redness. That tissue destruction continues for days. A lot of times people end up with a very substantial necrosis and are going to end up with tissue transplants, or having some sort of a reconstruction done. So other things that kind of go along with their tissue issues, obviously it's painful, nausea, vomiting, they get some chills and some fever as their body reacts to it. Most of them are not fatal. They're just plain not fun. Then we have the black widow. The black widow, just like mosquitoes, only the female is a problem. The male black widow actually is much smaller and looks quite a bit different than the female does. The female black widow is characteristic of the pitch black body with the red hourglass on the underside. So seeing them from the top, you might see a little red mark on the top. We have those little spiders run around here in the Midwest, but those are not black widows. The black widows have their red underbelly hourglass sign. They are not very common around the Midwest. They are mostly coastal, including up by the Great Lakes, but they are not common around the Nebraska, Iowa areas. The black widow actually has a potent neurotoxin, so it starts to cause spasms of muscles, can cause some changes in mental status, some seizures, as well as your nausea, vomiting, diarrhea, things that go along with typical poisoning. But it is a shiny black spider with a red or orange hourglass. Only the female bite is dangerous. It has a potent neurotoxin. It actually has another relative that's recently been identified in the United States as the brown widow. Same basic concept, only it's a more brownish body than it is a black. It's still the female. Remember that the black widow, much like many of the mantises or mantid family, after they mate, she kills her male mate. So it's kind of a lifelong commitment for the males. But in general, treatment is all going to be, again, supportive. IV access is going to be nice, and potentially some of these pieces are going to have really severe pain. We're going to want to try to give them a little bit of analgesia. Now, occasionally they may have some signs of shock. We'll treat those appropriately. But interestingly enough, all spiders are venomous. There's only these two major classes in the United States that are actually poisonous to humans. So we shift somewhere to, say, Australia, where in Australia closer to 50% of the spider families are poisonous towards humans. So all spiders have venom. Either they have too small of fangs to actually do anything to a human, or their poison just doesn't affect us. So in the United States. Common misconception is that daddy longlegs are a venomous spider that is really venomous towards humans, and that they have just too small of mouth parts in order to bite us. In reality, what we call the Midwest granddaddy longlegs isn't even really a spider. It doesn't fit into that class because of the way that it is designed, and it is not venomous towards us. So, bark scorpions. Bark scorpion is found occasionally in the desert southwest of the United States. It is really the only one that causes any fatalities. It's pretty rare to run into. It's a very large scorpion. But scorpions are generally seen at night. All scorpions have a bit of venom in their tail. They don't bite, they sting with their tail. Of course, they have their little pinchers that I guess could give you a little nip, but they're not. They don't have any toxin in their pincers. Scorpions are nocturnal creatures. They hide during the day in most cases. Another interesting science factoid here is all scorpions under a black light glow in the dark. They don't know why, but all scorpions, all of them in the family, you take a black light out to the desert with you while you're walking around. The things that glow green are scorpions. So the venom of most scorpions is also neurotoxic, similar to that of the black widow. It causes cramps and seizures, muscle twitches, alterations in mental status. If you're dealing with some sort of an envenomation, snake, spider, what have you, occasionally they will recommend that you apply a constricting band. So basically your IV tourniquet. We're not putting a real full tourniquet on them like we do in trauma, but we may put an IV constricting band on them just above the site to help slow the distribution of toxin. It depends on protocol. Here in the Midwest, we don't worry much about that, so really not a big deal for most of us. Interestingly enough, though, one of the leading and most diverse supplies of anti-venom, or antivenin, as they sometimes call it, in the United States and the world for that matter, happens to be in Omaha at the Henry Dorley Zoo, because they have so many of the toxic animals, and then in relation to their being right in the middle of the country, it's a great place for there to be a store of these venoms, or antivenoms that can eventually get dispersed to where need to go. However, oddly enough, outside of the zoo, we don't have too many venomous things to worry about. The snakes. So we have two major families of venomous snakes in the United States, and however, the significant majority of our snakes in the U.S. are non-venomous. So we have, all of our common garter snakes, bull snakes, black snakes, and rat snakes and whatnot. Those are fairly common. We see them all over. Luckily, in our area, it is pretty uncommon for us to run into a venomous snake. The ones that we would potentially run into would be some of the various species of rattlesnakes. The various families and species of rattlesnakes sometimes are seen in the corners of the southwest and southeast corners of Iowa, and the northeast and southeast corners of Nebraska. Occasionally, we'll see a rattlesnake from time to time. Occasionally, we also get one that jumps off of a coal train passing through. They're really pretty uncommon. Water moccasins, while some people have said that there are water moccasins around here, they're not recognized as being a regular indigenous species. The copperheads are definitely not indigenous to around here. And then there's the coral snakes. the first three we talked about, water moccasins, rattlesnakes, and copperheads and their various subspecies, those all fit in the pit viper class. They have very distinctive features. They have long front hinged fangs. They have diamond or triangular shaped heads. They have elliptical eyes that look like a cat, or they have slits basically for eyes. And they're generally a fairly large sized snake. The coral snake, on the other hand, is actually the most venomous of all of them. And the coral snake is actually classified in the colubrids family. And the colubrids family of snakes don't have big long fangs. They don't have elliptical eyes. They don't have triangle-shaped heads. The colubrids are commonly found in the southwest, a little bit into the southeast, but not typically seen in other places. The coral snake will actually, when they strike, when a pit viper strikes, it strikes and withdraws. And typically, when a coral snake or a colubrid strikes, they hang on, and then they chew. And as they chew, that's how they start to inject their venom. So, talks about our pit vipers. Envenomation really depends a lot on the size of the bite. Sometimes they even have a dry bite where they don't actually inject any venom, kind of based off of the size as well. Typically, younger snakes have a little bit more potent venom. Usually when snake bites occur, it's either A, somebody was messing with a snake that probably shouldn't have been messing with a snake, or somebody was messing with the snake and for educational or scientific purposes and gets bit by accident, or somebody steps on or near a snake, frightens it, and it rears up and nails you. Typically, pit vipers will have a painful, discolored, swollen site. There will be some tissue necrosis that can lead later on to some nervous system issues similar to that of our arachnid bites. So we can get some cramps and some alterations in mental status, seizures. You can also start to have some things like unresponsiveness. With the coral snake, while very rare, there we go, weakness, chills, diaphoresis, nausea, vomiting. Ensure the snake is not nearby. Try to get a description of the snake. Don't pick it up and take it with you. Don't ice or put constricting bands on our pit viper bites. Don't elevate the extremity. Keep it in a neutral position. A lot of times they even recommend putting a splint on it to keep it immobile. The more you move it, the greater chance there is of moving venom through the lymphatic system. Basic supportive care. Again, you may be asked to put a light constricting band on. Start an IV. If they're going to need an antivenom, they're going to get it IV. Coral snakes, like I talked about, they don't fit the pit viper description. They have backwards oriented large fangs, but not nearly the big fangs that you see in the pit viper. So they'll use a chewing motion. 40% of bites are envenomated with the coral snake. They resemble a lot of harmless snakes. They'll have red, black, and yellow bands. And in the United States, this works. This does not work everywhere, but in the United States, red on black, venom black, red on yellow, kill a fellow. So, or red on black, friendly jack, I've heard. But red on yellow, kill a fellow. So if the red stripe touches the yellow stripe, it's probably a coral snake. If the red stripe touches the black stripe, then that is probably a milk snake, king snake. There's a few others that use the coloration of the coral snake as a way to influence others to not mess with them. They do have a very potent neurotoxin. It'll cause some paresthesias, cranial nerve dysfunction, weakness, twitching, respiratory failure. You can apply a compression bandage. After wrapping the extremity, you'll splint it, keep it level with the body. Similar, all the snake bites really kind of get the same kind of treatment there. Do not apply ice. Marine animals. So when we have marine animal envenomation, we're talking freshwater and saltwater animals can be venomous. Most cases we're talking saltwater animals, so we're talking things such as jellyfish, stingrays, corals, urchins. Stings or punctures can be very painful. They typically will lead to itching and a raised welt or a wheal. In severe cases, can also include nausea and vomiting, diarrhea, abdominal pains, lymphadenopathy, difficulty breathing, chest pain, muscle cramps. Some of the jellyfish in the Indonesia and Australia areas are deadly, such as the irukandji. There are some very, very tiny little jellyfish that are ridiculously small, but have some of the most dangerous toxin. Jellyfish have something that are referred to as nematocysts. Nematocysts are basically little spring-loaded harpoons that are in their tentacles that inject their venom. So you don't usually come into contact with just one. You come into contact with a couple hundred of these nematocysts at once. They fire into you and spear you with their little bits of venom. From what I understand, they're extremely painful. If you've ever, in the freshwater environment, gotten prickled by a catfish's whiskers or spines, you probably can relate to some of the painful sting that you get. The catfish or the bullhead, their spines and whiskers can have the little prickle that is really irritating and can be painful. So for saltwater bites and stings, flush the area with saline or 70% alcohol or vinegar. I've also heard some people using meat tenderizer, which helps. It's not absolutely wrong to use urine. It works. Just probably not the cleanest way to go about that. And could make things socially awkward for you in the future. So when we're removing stingers or nematocysts, you're going to scrape those away, much like if we were to be stung by a wasp or a bee. Actually, the bees are the ones that typically leave their stingers, where wasps retain theirs. If we need to remove them, we do so by scraping. So you would take something like a credit card or a knife blade. Don't press the knife blade down into the skin, but rather drag it across the skin like you were shaving it. So credit cards are usually, or if you have a safety razor that you use, like to remove hair from somebody's chest to do an EKG, that would work as well. Heat will help inactivate the venom, and it helps relieve some of that local reaction. So that's kind of why urine works kind of twofold. Number one, it's warm, and number two, it has some of the content that will help release and reduce the venom. In severe cases, we'll talk about patients developing respiratory distress and shock. A loose constricting band, again, may help slow the venom through the lymphatic system. Scrubbing or tweezing the stingers can help release more venom. Same sort of thing when we're talking about bee stings. So that's why we don't reach down and squeeze them. We scrape them away. We can actually squeeze the venom sac and inject more venom. So again, in most cases, we are able to get a fairly accurate history from our patient of what happened. Hopefully, they'll be able to assist us in identifying what was the offender. Some cases, though, we may not be aware of the bite until later, so such as brown recluse, occasionally coral snakes. And in addition to the venom, be aware of the infection risk. All right, so now we're going to talk a little bit more about the use of specific drugs and medications. So over the counter, these are very readily available, and they figure prominently in suicide attempts. Oddly enough, many people use kind of ridiculous things like Tylenol or ibuprofen to try to kill themselves, which if people would do any research at all, they would know that that's the terrible way to go, because you're either going to destroy your liver, you're going to destroy your kidneys, and you're going to have a long, painful death. You may not even be eligible for an organ transplant because of your actions. So it's going to be a long, ugly, painful death, and that's not what most people are probably intending when they make some sort of an attempt. Now, if it was truly a gesture or an ideation, and they had no true want to die, now that's just plain sad, because now they are going to most likely die or have a very ugly outcome of this when it was unintended. So a lot of people underestimate the potency of many of our OTCs. So acetaminophen or Tylenol, widely used pain reliever, top 5 medication with the largest number of associated fatalities. Top 5 medications in the world with the largest number of associated fatalities. That's terrible. It does not have a very wide margin of safety, so the lethal dose of it is really not very far from what our typical therapeutic doses are. People feel that it's relatively safe. They don't understand that how bad it is on the liver and how much it can go and cause liver failure and a hepatitis, if not cirrhosis and death of the liver. The relatively low level of about 7.5 to 15 grams in an adult or 150 milligrams per kilogram in a pediatric can be a hepatotoxic dose. So it can have permanent effects on your liver in such a small amount. Most people, when they take extra strength Tylenol, are taking 2 500s, so they're taking 1,000 milligrams. You're not supposed to do that any more than about 4 times a day, so that puts you at about 4 grams. So you can see that we do a couple extra doses in a day's time, we can find our way into the hepatotoxic dose very easily. So in the short term, acetaminophen is relatively asymptomatic, so they might get a little sick to their stomach, but really don't see any side effects. Within about 24 hours, though, the liver failure starts. There is an antidote. It's called N-acetylcysteine, also called Mucomyst, and that gets used for some various other problems, such as respiratory distress of certain types. But it is an antidote that will go in and reduce some of the effects. We may also have people who think that aspirin would be a good way to overdo it. Now, I think most people that actually overdose on acetaminophen probably do it unintentionally. We certainly do have those that are trying to do something. Aspirin, we know that a lot about aspirin. It's an analgesic, a platelet inhibitor, salicylate, it helps with fever. If they discovered aspirin today, it'd probably be like $7 a pill. Luckily, it was discovered a long, long time ago, so we can get a bottle of 100 of them for $1. So it's got a lot of definite good effects, but there are other drugs that fall into the salicylate family that might be taken in conjunction. And an example of that, Pepto-Bismol has bismuth subsalicylate in it. Or we have methyl salicylate, or the oil of wintergreen, which we sometimes have in some of our arthritis or muscle pain agents. So we can compound the problem of too much salicylate in our body. A level of about 300 milligrams per kilogram is required for toxicity. And again, when we're taking aspirins, we're probably taking doses of people who take it on a daily basis for their heart are taking 81 milligrams, which is pretty safe. But people who are taking it routinely for aches and pains and fevers are probably taking 650 milligrams at a time. Take that a few times a day, and you can work your way up there pretty closely to your 300 milligrams per kilogram. So you got to be kind of cautious with that. They may not be aware that they are actually taking multiple products that is compounding this issue. Salicylate acid acidic toxicity causes metabolic acidosis, and it can impair the cellular energy production. So the body's into a cellular acidosis. It causes it to flip into a anaerobic metabolism. Biggest complaints that come from this are gastrointestinal distress because it causes so much acidity in the stomach. Also causes some dizziness, ringing in the ears or tinnitus, hyperpyrexia, so it's a rebound fever, confusion, vomiting, heart failure, dysrhythmias, pulmonary edema. One of the best things that you can do if somebody has actually overdosed immediately on this and it's been a short period of time, the use of some antacids will go quite a long ways in helping to reduce some of the metabolic acidity. It doesn't necessarily take care of all of the problems that are associated with an aspirin overdose, but it can help offset some of the acidity or the metabolic acidosis. We have other things that people will attempt to take, antihistamines such as Benadryl. They have anticholinergic properties. They try to dry our mouth and our nose and our snot and our thirst intentionally. That's what they're used for, of course. But sometimes we'll overdo those because you might take something like, well, I'm having some issues with my allergies and I'm not sleeping well, so I've taken some Benadryl to try to help with my allergies, and so then I decide I'll take some Tylenol or some Advil PM to help me get a little bit better rest. Well, the PM products have Benadryl in them. There are some sleep aids that's strictly all that's in them is Benadryl. Benadryl makes you sleepy. It's a side effect. So some of the drug companies actually have capitalized on this and said, oh, well, if it makes you sleepy, here, we'll sell it as sleep aid, even though you can probably buy it cheaper as a antihistamine, because that's what we've used it for forever. And if you compare the ingredients, both of them probably, each pill probably has 25 milligrams of diphenhydramine in it. It's the same stuff. It can also lead to some blurring of the vision, tachycardia, hyperthermia, flushed skin, hypertension. Some other things such as iron. Iron can be very toxic. Unintentional poisoning for a lot of children. Just too much iron in the system causes GI disturbance, usually very, very dark stools, extremely dark stools. Nausea, vomiting, hematemesis, hypovolemia. Remember, iron is part of the hemoglobin system there. Systemically, iron interferes with the cellular energy production, causes a metabolic acidosis, and then will lead to failure of all of our important organs. All right, so we flip on over now to some of the prescription medications. We can talk about things such as benzodiazepines, sedative hypnotics, narcotics, antidepressants, psychotropic meds. These we touched on a little bit in the behavioral emergencies chapter. So we'll kind of recap a little bit more of the medical side of things now, as opposed to the psychological side. Benzodiazepines are commonly given to treat anxiety and promote sleep. So these are the things like Valium, Xanax, some other medical preparations, midazolam, Versed. Those are a few. Ativan can also be used for treatment of seizures. So a few of these medications people, it makes them sleepy, makes them feel good, reduces their anxiety. They don't typically result in deaths of overdose, but when they do, it's from such severe respiratory depression. Sometimes their altered mental status has gone down so far that they actually choke on their own vomit, and they aspirate. It does potentially cause some hypotension from time to time. It's not as dangerous as the opioids are, but certainly a concern. The first time I ever gave Valium as a paramedic, I gave IV Valium to a person having a seizure, and I gave just a hair too much. And that little bit of extra Valium I gave took their respiratory rate from about a 24 down to about an 8. So it made me a little concerned, but it was something that I could manage and I could control with bag valve mask and a little bit of O2, and was able to manage. Respirations didn't suffer for that matter. Narcotics, the opioids, morphines, codeines, toluene, dilaudid, heroin, fentanyl. We have synthetic and non-synthetic versions. So we may have things like fentanyl, which don't have, they're synthetic. They don't have nearly the negative side effects that we see with some of the naturals, such as morphines. They are controlled substances, usually used as pain relief, however sometimes used in either cough or to slow the gastrointestinal activity. One of the big side effects that people on narcotics have is they get constipated because narcotics slows down their GI tract. So overdoses will cause some CNS depression, can also cause some respiratory depression. We know that that's a big problem. That's why we give Narcan, right? Constricted pupils, one of the few drug classes that does that. Bradycardia, hypotension, pulmonary edema. And if they go untreated, they can be fatal because of the severity of their respiratory depression. So again, when we're talking some opioid overdoses, we're usually looking at managing the airway, so very supportive care is there. Naloxone to reverse the respiratory depression. Remember, don't wake them all the way up. Other drugs can also compound this problem. So if we have patients that are drinking alcohol, or people who are taking barbiturates, or maybe even benzodiazepines, all of these things can compound the CNS depression. So it's common for them to have some slurred speech, some altered mental status. They may have respiratory depression and hypotension. They have this polypharmacy thing going on here. It can be a much easier chance of causing some death from respiratory depression. So IV access, treating the hypotensions with some fluid, and really supportive cares still remains to be our theme here. Antidepressants. Antidepressants commonly get used in suicide acts or ideations. So people at high risk for suicide often will have access to these because they are being treated for something. They're being treated for some depression or some anxiety. We have a variety of classes of these medications. We have the cyclic antidepressants. I've spoken of those before. The TCAs, things such as amitriptyline and nortriptyline, Elavil. We also have the monoamine oxidase inhibitors, also called MAOIs. You'll hear about those from time to time on some of the drug commercials you see. If you take MAOIs, don't take this medication, because MAOIs don't get along well with a lot of other meds. So those are some older classes, and then our newer classes of antidepressants include our SSRIs, SNRIs, our NRIs, and then some just general miscellany class of antidepressants that don't really fit into some of the other categories. Remember, occasionally we find a drug that works for something that wasn't the original reason why it was invented. We'll take, for example, clonidine. Clonidine is actually intended to treat hypertension. However, it has some positive benefits as an antidepressant drug, and also helps people become a little sedated and get a better sleep. So sometimes we stumble into some of these discoveries. So selective serotonin reuptake inhibitors are probably the most common ones that we're seeing. SNRIs are catching on, though. The serotonin and norepi reuptake inhibitors. The norepi reuptake inhibitors alone are not as common. And then we have some of the oddballs, kind of like Abilify or aripiprazole. TCAs, the concerns about their safety and overdoses are huge. That's why they kind of get left now as the last resort. They are cheap. They have other uses. They sometimes get used in people with migraines or people with seizures. But some of those are listed in your text, of course. Another one, norpramine or desipramine, is another type, or Pamelor is another brand name there. And they work by inhibiting the reuptake of serotonin and norepi. They just do it in a little bit more dangerous fashion. They have a very narrow therapeutic index, meaning that they could go from therapeutic to toxic with just very small change in dosage. So it's not something terribly safe to go unmonitored. So TCAs cause anticholinergic issues. So the confusion, the hallucinations, hyperthermias, respiratory depressions, seizures, tachycardias. So the whole blind as a bat again. Here's what we typically will see with them. These are somebody that paramedics are going to watch very closely on the cardiac monitor. They tend to have quick onset, sudden cardiac arrests. So the treatment that the paramedics are most likely going to give for a person that's a TCA overdose, they're probably going to get some sodium bicarbonate to help offset some of the acidosis and to buffer some of that drug. MAOIs, or the monoamine oxidase inhibitors. This was the generation after the TCAs that they said, well, this is a little bit safer. Still have a few issues with these drugs as well. Marplan, Nardil, Parnate are some of the more common MAOIs. They occasionally also get used for a few other things, such as Parkinson's, but they don't play well with other medication or other substances. So foods containing tyramine, such as beer, red wine, chocolates, cheeses, processed meats, they don't play well with. Ingestion of those or the use of a lot of over-the-counter cold agents, cold and allergy preparations, can cause people to have hypertensive crises. So they spike the blood pressure up into the high 200s, over the 100s. So it is what happens is MAOIs inhibit the enzyme monoamine oxidase that breaks down norepi and therefore increases the actions of norepi. So when we have additional parts there, then the norepi actually starts to really take off. So we have signs or symptoms of a serotonin syndrome, which would be things that we see from SSRIs in most cases. So our SSRIs are things like citalopram or fluoxetine, Prozac, Zoloft, Paxil, Lexapro, Cymbalta, Pristiq. Some of these are also falling into the SNRI categories. But signs or symptoms that we might see for overdoses on these: agitation, anxiety, insomnia, headache, sleepiness. So we got both ends of the spectrum. Diarrhea, salivation, goosebumps, flushed skin, hyperthermia, tachycardia, muscle rigidity, shivering, ataxia, myoclonus. So pre-hospital management, again, is going to be symptomatic and supportive. We tend to have a theme here. We're supporting the ABCs. Neuroleptics. Neuroleptics get used as antipsychotics, as sedatives, and antiemetics. So some of the things that fall into here are the azine drugs: phenothiazine, chlorpromazine, prochlorperazine. We also have some of the other newer agents that are used primarily for psychotics, so Geodon, olanzapine, Zyprexa, aripiprazole. We also have napsine, Haldol, that all fit into this neuroleptic category. They can cause a neuroleptic malignant syndrome, which basically causes a major alteration in mental status, severe muscular rigidity, fluctuating blood pressures, tachycardias, hyperpyrexia or high fevers, diaphoresis, and rhabdomyolysis. So basically, it's putting all this tension and stress on the muscles starting to break apart, and that causes rhabdomyolysis, which we know can clog up our kidneys. So it also can occasionally cause a lethal cardiac dysrhythmia called torsade de pointe, and that means the turning of the points, if we translate it, but basically it means a V-tac that's coming from different angles. We talked about V-tac before. If you really are interested in that, if you look at page 1088 in the back of the book, you've got a V-tac. That one is called monomorphic, but when you actually it starts to twist around a little bit, it becomes torsade de pointe. So you can look it up on Google. It's pretty cool. But so that neuroleptic malignant syndrome. We also have people who take things such as lithium. Lithium is used for mood stabilizers, bipolars, and for patients with schizophrenia. Its symptoms include GI complaints, dry mouth, tremors, lethargy, confusion, seizures, coma, muscle tremors, bradycardias. In many cases, the toxicity is chronic rather than acute. This is one that they will be monitored closely with. They're taking lithium, and they'll monitor them pretty closely to make sure that they're staying within their therapeutic range. And they mentioned that activated charcoal is generally not recommended for lithium because it won't absorb it. Cardiac medication toxicity. This one can be all over the road, simply for the fact there are so many different cardiac medications out there. It can be extremely difficult to pinpoint which drug we're talking about and what exactly it's going to do. So suspect this poisoning and overdose if you have a patient with altered mental status, bradycardia, or tachycardia. So beta blockers are a very common class of drug. These are the OLOL drugs, so metoprolol, atenolol, propranolol. They are used in most cases to control either the heart rate, so keeping the heart rate lower, or to control the blood pressure and keep the blood pressure lower. So it blocks beta. It blocks that epi and norepi and its effects. Calcium channel blockers, another enormously used class of drugs. This blocks the calcium channels along the edges of the cell. So when sodium rushes in, usually calcium also rushes in through its channels. But this helps reduce the ability of calcium to do that. So again, it slows the heart, it lowers the blood pressure, and it can actually also treat some of the angina by causing the muscle to start to relax a little bit more. Digitalis, digoxin. This is the one that is the cardiac med or cardiac glycoside that comes from the foxglove plant. It is, again, used to control heart rate, most commonly used in patients with atrial fibrillation. The other name, Lennox in there. Toxicity easily occurs. They generally will watch these patients very closely. They'll have their levels drawn to make sure that they remain in their therapeutic range. Signs or symptoms include loss of appetite. This is usually a longer onset sort of thing because these people get toxic over time. Nausea, vomiting, headaches, diarrhea, blurred vision, yellowy-green vision, mood changes, confusion, bradycardia, and cardiac dysrhythmias. So not all patients with narcotic overdose require Narcan. Naloxone is titrated to improve their respiratory status. But the goal is not to restore alertness. They may become more alert in the process, but basically our goal is to try to get their respirations back up. With the alertness, it causes agitation, it causes withdrawal, and again we have kung fu fighting going on. So also the duration of naloxone is shorter than that of some narcotics. So naloxone hangs around for maybe around an hour or so before it starts to bug out, in which some of our narcotics stick around for several hours. So we can start to see later in the process the patient's mental status and respiratory drive dive back down as the narcotics kind of take back over. So we move on to street drugs. We have a couple of different classes of street drugs we'll chat about for a moment. We have the stimulants such as cocaine, methamphetamine or amphetamines fall into this category as well. The cocaine causes, it comes from the chemical processing of the leaves into cocaine hydrochloride. It can be inhaled, it can be injected as a liquid, and that's crack cocaine is also smoked. So there's all kinds of different routes you can take it. It's almost an immediate effect, either through inhalation or through injection. And then it's relatively short acting. But it increases our dopamine at the synapses, causes a euphoric, energetic, alert feel, and both the appetite and the need for sleep is decreased. So this, it's an upper, it's a stimulant. So this is what what people are sometimes looking for. It's going to help me lose weight, suppresses my appetite, keeps me awake, keeps me going. An example of the cocaine animation, and you can watch that out of the other PowerPoint. However, it's also a very potent vasoconstrictor. I've showed some people a vial of medical cocaine. Cocaine actually does have a medical use. It's used as a vasoconstrictor, so it's going to increase the heart rate a little bit. Typically increases the body temperature. Blood pressure typically goes up. Oddly enough, medical cocaine is used for nosebleeds, which you would think cocaine would actually cause. But medical cocaine gets dabbed on some gauze, and the gauze is then packed in the nose to help constrict all those vessels. It can also cause agitation, irritability, paranoia, psychoses, and violent behaviors. In some situations, even leads to stroke, MIs, cardiac dysrhythmias, and seizures. But it also results in a tolerance and a physical addiction. So it causes withdrawals when you're coming down off of it. We have the amphetamines. Amphetamines used to be very, very common in the diet pills. Most of them have been taken off the market. There's still a few. But it's most commonly given to people with either ADD or ADHD as a way to stimulate their concentration, to focus. It increases both the levels of norepi and dopamine. It gives a similar effect that of cocaine. There are some legal versions. There are some illegal versions. We have, the clandestine methamphetamine. Obviously, that's made usually in people's bathtubs or whatever. But things such as Dexedrine, which is a diet pill, Ritalin, and Adderall, which are both used for ADD, ADHD, those are all types of amphetamines or uppers or stimulants. They're either taken orally through ingestion as in a pill form. They may be injected, they may be inhaled or smoked. They can cause a tolerance and a psychological and physiologic dependence. Sometimes people who do take some of these ADD and ADHD drugs actually really depend on them in order to help them keep their concentration. Sometimes we'll also see behavioral changes. In some cases, it almost has a zombifying effect in some patients. But sometimes it is an over-the-top thing, particularly if it's being used off-label. So violence, seizures, hypertensions, hyperthermias, tachycardias, tachydysrhythmias, and occasionally are also implicated in deaths due to excited delirium, which we talked about when we have that psychiatric patient or apparently behavioral emergency patient in police custody. Occasionally the patient ends up arresting. We have some hallucinogens such as PCP. In PCP, phencyclidine, this was a dissociative anesthetic that was developed for use during surgery. However, it was found to be pretty ugly little drug. So it's related to ketamine, which is a horse anesthetic that has actually been now started to be refined for some human use, but it typically would be smoked, injected, ingested, or snorted. PCP is only available today as an illegal street drug because it just was not an appropriate agent for use in medical science. It causes people to be belligerent, become extremely agitated, violent, psychotic, diminished pain response. These are some of the people who have superhuman strength that are flipping over cars, they're getting shot 6 times and keep coming. These people are unbelievable, jumping off of 3rd-story balconies and still running away with a broken leg. So other signs of a PCP overdose: nystagmus, ataxia or slurred speech, hypertension, tachycardia, behavioral changes. They're again at a risk of excited delirium, rhabdomyolysis, because they're going to do a lot of these things that they think they have this superhuman strength that actually ends up being they're not as strong as they think they are, and it causes excessive damage to their muscles. They can have hypertensive crisis, respiratory depression, seizures. So activate law enforcement early. Physical and chemical restraints may become necessary, almost will become necessary if you can get them restrained to prevent harm. And we need to try to cool this patient because they're probably going to be hyperthermic. They're in a hypermetabolic state. So we typically will try to cool them with water. LSD. LSD is also called acid. And LSD is derived actually from the ergot fungus. Ergots are a type of basically kind of like a corn smut. But they're a type of fungus that grows in some types of crops. And I believe corn tends to be one of the most common places that it grows. But it has some very interesting psychological effects, some hallucinations, depends on the user, and any external stimuli. These are the people who are smelling colors and hearing odors and whatnot. It is ingested in most cases. Usually it's either in a little stamp form that gets placed on the tongue. Sometimes they'll even place it on their eyeball. It was researched by the U.S. government for various purposes and determined that no, this probably isn't a very good idea either, so we're going to not continue to produce this. Well, the people figured out how to make it. So it is used strictly as an illicit or illegal drug these days. Typically, these people will have some anxiety, panic, and paranoia. So these guys are having their acid trip that I'm sure you've heard of. A few other different hallucinogens around there. Mescaline, this comes from the peyote cactus. And it causes some illusions, some sensory misperception and hallucination. People say an expanded sense of consciousness. Psilocybin. Psilocybin comes from your magic mushrooms. Interestingly enough, psilocybin grows on cow pies, so have at her. But psilocybin mushrooms grow on generally on feces, so they're metabolized into psilocybin, and it has a very high psychedelic effect. An overdose causes nausea, vomiting, weakness, and ataxia. Example of intravenous drug use. Of course, we have narcotics, the opiates, derived from the opium poppies. We've already kind of talked about the opiate class before when we were talking about the common street drug or the common medications, but we also have those that are less than savory in the way they get them. So heroin being one of those. They can be either obtained legally or illegally and then abused that way. Typically they're ingested, although heroin is typically injected. We talked about how we had synthetics and natural narcotics. We also have the hallmarks of it being constricted pupils and respiratory depression. They also usually will have sedation and, in many cases, track marks if they're injecting. If they're taking it orally, you're, of course, not going to see the track marks. Over time, drug abusers get pretty slick with how they hide where they inject their drugs. They start running out of places, so they start looking for other places, such as injecting them into their genitals or between their toes, or they find new places to put them. All right, so what street drugs are particularly a problem in your community? You know, I can speak for what we see more commonly around here. Methamphetamine, of course, is still big. Marijuana is big. Marijuana is still illegal in most of the states, as it is in Iowa and Nebraska. Yes, it is gaining more and more universal acceptance, but yet remains illegal. It is a hallucinogen and a sedative. What toxic substances do you have around your house? You name it, you probably got it. And how can you make your home safer? Well, if you've got little ones around, hopefully you've baby-proofed. If you don't have little ones around, you still need to pay attention. I mean, it's easy for things to get mixed up. Don't put things into other bottles without marking them. Some other drugs of abuse, GHB. This is also known as the date rape drug. It's an anesthetic agent. It also causes sedative hypnotic effects, and it causes a disinhibition of behavior and enhanced sensuality. So there are versions of it that also get deemed ecstasy and liquid X, liquid G. There are other things that can sometimes also be abused, such as ketamine. They'll call it vitamin K. I mentioned this before. It's actually commonly used in veterinary practice as an anesthetic, but people use it as a drug of abuse. GHB can cause a dramatic respiratory depression. Also causes equally dramatic improvement in minutes to hours later. Dextromethorphan, which is commonly found in over-the-counter cough syrups. Anything that has DM in it is dextromethorphan. It's a dissociative. Kids have found this. They're buying over-the-counter cough syrups and taking a robo-trip on it. It's typically by Robitussin, and they are occasionally misusing that. It causes some sedation. Marijuana we talked about, and they can both lead to some paranoias, anxieties, dry mouth. It makes sense with the cold medication to kind of dry out, dilation of the pupils. And again, most of this chapter, we found that there's only a few things that we can really do. Sometimes it's cooling people down a little bit. Sometimes it's just providing ABC support. We know that naloxone works in a few occasions. Some of our patients get a little dry, so we can provide them with some fluid resuscitations. But all in all, there's not a lot we can do for a lot of these patients. Patients who are on stimulants that are really gone into kind of a hypermetabolic state, paramedics may be able to administer a little Valium or Versed to kind of bring them down. But for the most part, we're very, very supportive in this chapter because we don't have tons and tons and tons of antidotes. So poisoning and overdose are common reasons for emergency care. Sometimes they bypass us and go directly to the ER. It's nice that we have a general appreciation for the various types of substances and drugs that are out there that we're occasionally running into. So to understand them a little more helps us potentially be better prepared to treat these patients should we run into them. Remember that we try to classify most of our substances into different toxidromes. The things that we start to see become more prevalent, we would want, of course, to spend more time studying. So if we see maybe we have a new drug that comes out, we want to learn more about that drug so we can classify it into a toxidrome. We have 4 major routes of the toxins get into our body: ingestion, injection, inhalation, and absorption. A thorough scene size-up is essential to both establishing safety of the scene and gathering information about the emergency. Our goals are to decontaminate, to limit our exposure and the patient's additional exposure, and maintain our ABCs in a supportive manner. IV access can be very important, not only for fluid therapy and for patients with hypotension, but occasionally for those patients who also we have an IV medication that we can assist them. So something like Narcan, or if we have paramedics come along, it could be things like Valium or whatnot. Consider the need for paramedics for patients who have an additional airway management need or when cardiac dysrhythmia is anticipated. Don't forget decontamination needs to play needs to be at least a consideration in our mind before we go transporting patients and exposing everybody else to the toxins. The 2 medications that AEMTs give in toxicological emergencies are activated charcoal and naloxone. However, activated charcoal is generally not recommended and could be interpreted to actually not even be in your scope. Always consider the possibility of polysubstance abuse, the presence of trauma or medical conditions. And your poison control center can be an extremely valuable resource.